All right. Good morning, everybody. Welcome to Neurosurgery Grand Rounds here at Swedish Neuroscience Institute and Seattle Science Foundation. I'm Zach Litvak, and it is my pleasure this morning to welcome Dr. Gustavo Pradilla from Emory University. Dr. Pradilla is Associate Professor of Neurosurgery and the Chief of Neurosurgery at Grady Memorial in Atlanta. He's joining us this morning to give us an overview and then a state-of-the-art discussion in terms of management of intracerebral hemorrhage. Dr. Pradilla, welcome. Thank you for being here.
Thank you very much. Good morning, everyone. Thank you so much for the opportunity to share some of our work with you. I'm going to go ahead and share my screen. Is that showing well?
Yep, we can see it.
Okay, great. All right. So intracerebral hemorrhage is a very common problem in neuroscience centers across the world. And it's a condition that continues to expand. And in the next 45 minutes or so, I will discuss first the problem and one of the solutions that we have developed for it that is undergoing testing and evaluation through a randomized clinical trial. And then we'll briefly touch on other exciting things that are happening in this field. These are my disclosures, and the most important one is that the ENRICH clinical trial is sponsored by Nico Corporation, and they manufacture some of the devices that we use for the procedure. So as I mentioned, this is an important endemic problem. The mortality of these patients continues to be very high, and the economics of this disease are staggering. And we in the cerebrovascular world spend a lot of time talking about treatment of aneurysms and AVMs, and with the development of thrombectomy, that has become front and center in cerebrovascular interventions. But ICHs are still a very significant portion of that patient population. And if you look at the main etiologies for intracerebral hemorrhage, hypertension, amyloid angiopathy, and anticoagulation, all of those continue to rise with an aging population. And nowadays we have more patients on anticoagulants than ever before. Seems like every month there's a new anticoagulant on the market. And we keep seeing more and more iatrogenic intracerebral hemorrhages. So in terms of the rationale for clot evacuation, when you see these pathological slides and you see this disease live, it's an intuitive thing to do, but you'll be surprised at how many times we failed at it, and we're going to talk about it. So in my mind, there are three reasons why we should treat this hemorrhages surgically. The first one is to control intracranial pressure. The second one is to prevent clot expansion. And the third one is to prevent the secondary inflammatory cascade, and I'll touch on each one of these points. So in terms of controlling intracranial pressure, whenever you have a hematoma that is greater than 30 cc's, intracranial pressure is an issue. And the reason to improve it, obviously, is to improve cerebral perfusion pressure, to decrease the ischemic injury that happens to the area around the hematoma. But also, very importantly, many of these patients with ICHs, they die primarily from complications related to their ICU stay. They die from pneumonias, pulmonary embolisms, sepsis, etc. And if we can do an intervention where, let's say we are unable to change the neurological outcome, but their ICU length of stay is decreased and we expose them to a lot less of these complications, that is still a positive result. So I'm gonna just play a very brief video here at the bottom right, where if you look carefully, there's an ICP monitor there. This is a slightly unusual situation because it's a patient that came in with a traumatic hemorrhage that became then an intracerebral hematoma. And that's why they had an ICP monitor. But the ICP monitor is 19, and this is under anesthesia. It's about 20. And then when the hematoma is evacuated, which is at this point, the hematoma has been reached, the ICP plummets. It's dropping now 14, 11, 9, 7, 6, 4. And that's the speed. This is a real-time video. This is the speed of the intervention that we're talking about. Can we do something so that that ICP can be controlled quickly and efficiently? The second reason for evacuating these hemorrhages is to prevent clot expansion. And we know from multiple studies from this group and others, this is the Mass General group led by Javier Romero, that any patient that shows up with a positive spot sign with active contrast extravasation has a very poor outcome. And we all see these two CT scans playing out where we get called in and there's a patient that presents with an image on the left side. And while we're trying to get them sorted out and get them into our ICU, we get called back saying the patient has deteriorated further. We get another scan and the hemorrhage has exploded and they're beyond something we can help. And we think that if we're able to do this, what I'm trying to show you there is the vessel that originated the hematoma. If we're able to get to the vessel that caused the hematoma, then the risk for expansion is a lot less. And that's one of the important goals. When we think about all ICHs, these spot signs are present in almost 25% of them. So it's an important population of patients that if we're able to stop this active hematoma expansion, we'll have a greater chance of survival and better outcomes. And then the third reason is to prevent the secondary inflammatory cascade. So when we have a patient that shows up with a hematoma like this to our ICUs, they may have a fixed motor deficit, maybe some issues with language, but they're going to be protecting their airway and be doing fairly okay. And we know that between 0 and 4 hours of that event happening, there are these events at the cellular level that cause a lot of dysfunction. However, if we decide not to intervene and we leave the hematoma in place, between 4 hours and 7 days later, all of these factors, red blood cells, hemoglobin, thrombin, they result in this pretty significant endothelial and microglial activation. And that leads to this cytotoxic, pro-inflammatory, and pro-oxidative state. And that eventually leads to vasogenic edema. So this dark halo that you see in the CT scan around the hematoma just prolongs. And a couple of days later, you get a call from the ICU saying this patient is now intubated and they're worried about malignant intracranial hypertension. And now they're calling for a life-saving decompressive hemicranial. So we think that there is a window of opportunity to decrease the impact of this secondary inflammatory cascade. And the molecular players that participate in this are fairly well known. And we know at what point, what cellular population starts to be more predominant. So we have a sense of what our time window is on the biomarker and cellular level. But it's obviously a time-dependent response. Perihematomal edema has been studied extensively. This is a study that was done by the MISTI investigators. I will talk about what the MISTI approach for ICH is in a minute, but what we learned from that is that if you evacuate the hematoma, there's less perihematomal edema that forms. And when there's less perihematomal edema, patients have better neurological function afterwards. So it is an important topic. So if there are all of these reasons to do this, this is not one of my videos, there's a source at the bottom, but it just seems intuitive, like a very positive thing. You see that high pressure hematoma just coming out and the brain relaxing and pulsating again. So it's a very intuitive thing. Why are we not doing it more? There are several reasons. The first one is this one. This is the Stitch trial. This was a multi-center randomized trial that was published in the Lancet in 2005. They had 1,000 patients from 83 centers in 27 countries that were split into two groups. One was early surgery, which they considered to be done within 72 hours, versus just medical management, supportive care. And the results of that study showed that 26% of the patients that had surgery had a favorable outcome versus 24% of the ones that were treated medically. Unfortunately, that was not statistically significant. And there was a subgroup of patients within that study, patients that had a lobar hemorrhage without interventricular hemorrhage, that was subsequently studied in the Stitch 2 trial. This had less patients, 600 patients, and it also compared early surgery to medical management. And unfortunately, the results were similar. So the patients that had surgery, 59% had an unfavorable outcome versus 62% in the conservative treatment group. Slightly better, but not statistically significant. And there was a 21% crossover to the surgical group. This was published in 2013, and these two studies have been the pillars to say that, or to guide the decision making and the guidelines to say that surgery is not beneficial. Now, as with any clinical trial, we can dissect it and do the postmortem and find many shortcomings. And I'm going to talk about those, but these are the main reasons why surgery is not the mainstay of therapy. These three gentlemen, Dan Hanley, Mario Zuccarello, and Osama Wood, put together the MISTY approach. The MISTY approach, as you see in that cartoon in the bottom, involves placing a catheter within the hematoma using stereotactic guidance, doing some gentle aspiration after the catheter is in place with a syringe, and then starting an infusion of TPA to thrombolize the hematoma. And they did some pilot studies. They did the MISTY 2 study, and they had very promising data in terms of clot evacuation, reducing length of stay, and reducing costs. So they put together this very large effort called the MISTY 3 study. That was, again, a randomized, multi-center, international controlled trial. And the results were published a couple of years ago in the Lancet. And there was a benefit for morbidity and mortality, a benefit for mortality. So these are the Kaplan-Meier curves. You see the patients that were treated with the MISTY approach are in blue at the top, and the patients that were treated medically are in red at the bottom. So there was a mortality benefit when they did this for all-cause mortality. But their primary outcome measure, which was a modified Rankin score, the difference was that the MRSs from 0 to 3, the good results, were 45% in the intervention group versus 41% in the medical group. So not statistically significant. They calculated it with an extended Glasgow outcome scale, and it was the same. 39% of the patients had a favorable result with the intervention versus 36% for the medical group. So not statistically significant. That was a big blow, but we did learn a lot of lessons from that study. This is a graph that shows you what happens when you have different volumes of the hematoma. So if you have a lot of residual hematoma, let's say 100 cc's, your probability of achieving a good modified Rankin score is very low. But if you have a low volume remaining, your probability of achieving a good modified Rankin score is actually pretty high. And for the first time, this trial gave us a goal, and that goal has been established at 15 milliliters of 15 cc's of blood. If you're able to decrease the volume to that amount, the chances of achieving a good MRS are significantly higher. They also did it in percentage points, and if you're able to evacuate over 70% of the initial volume, then the chances are good. So why did they fail? Well, unfortunately, they only got to that end of treatment volume of less than 15 cc's in 59% of the patients. We can't say that if they had achieved that end of treatment volume in 75%, that the results of the study would have been positive, but it certainly makes sense. So what went wrong with all of these studies and trials? So for the STITCH trial, a few things. The STITCH trial, again, was comparing just conventional craniotomies. And that was part of the problem. The technique of that trial said that the procedure could be done with the method of choice of the responsible neurosurgeon. And as you can imagine, this study had 1,000 patients in 83 centers in 27 countries. So there were some centers that did a big decompressive craniectomy and left the bone flap off, the dura open, and they did a clot evacuation. There were other centers that did a very small, kind of minimally invasive craniotomy. They evacuated some of the hematoma and closed. So the variability in technique was massive. Second problem is that the enrollment window was 72 hours. And we look at the biological data, by then, this vasogenic edema, this inflammatory cascade has already been triggered. The other problem was that they didn't know how they did. There were no post-surgical scans recorded. So they don't know what the clot evacuation rates were. So they don't know if they did a good job or not. So there were a lot of methodological issues in the trial, and that's one of the reasons why that failed. The other one is that when you look at how the surgeries are described, it's very likely that they used approaches that were disrespectful of the subcortical white matter. And I'll talk about that a little bit more in detail, but there were several cases where a lobectomy was performed to get access to the hematoma, frontal, temporal, or partial parietal lobectomies. That might have had something to do with that. What about MISTI? Well, the enrollment window of MISTI was also 72 hours, and you're already getting into patients with a lot of edema at that point. The other problem is that it takes time for the hematoma to be thrombolized. So if you put the catheter in and you're waiting for that thrombolysis to happen, it could take up to 5 or 7 days to reach that ideal volume. And by then, you're adding all of these days of the patient being in the ICU and intubated and being exposed to all of these related problems. And that was an issue. And also they had a lot of variability among centers. Some of the centers had really good clot evacuation rates, while others had very marginal evacuation rates. So the performance of the surgeons across the trial varied quite significantly. Another problem that is common to this trial is, or these trials, is that although we tend to lump all of these hemorrhages into this banner of intracerebral hemorrhage, the course, the clinical course and the behavior for these types of hematomas can be very different. A patient presenting with a lobar hemorrhage that is high like this, they can tolerate a fair amount of intracranial hypertension. Patients presenting with a deep basal ganglia, they behave very differently, and we may be able to move the post in terms of motor recovery if we take pressure off the internal capsule. That's a much different concern to patients with a thalamic hemorrhage, where the hematoma frequently dissects down into the midbrain and the patients are primarily just obtunded for a long period of time. So trying to get meaningful results in these clinical trials when we lump all of these locations and different patient courses together is a challenge. So when we looked at the state of the field after these trials were published, this is what we were faced with. Number one, patient selection. There are limitations as to what patients you can help, and identifying the best patients for the trial to be successful is a challenge. Timing of the intervention. We don't have a clinically defined therapeutic window, but we do have a lot of preclinical data, and we have some biomarker data, and we have some animal model data, and all of those confirm this window of inflammatory cascade being around 24 hours. And then the how, the technique used in the Stitch trial, which was a conventional craniotomy with some transgressions of the brain and partial lobectomies, did not lead to better outcomes. So maybe we have to try something better than that. Technology, a lot of things have been developed since those studies were conducted in terms of imaging, surgical access, visualization, resection tools, and those may do a better job at being respectful of the subcortical white matter in the cortex on the trajectory to evacuating the hematoma. And then the last part is training and education, standardizing a technique that can be taught to anyone easily and performed easily by anyone with the right equipment. It's an important part of this. So thinking about what's the ideal surgical procedure for intracerebral hemorrhage, these are the 6 things that we think should be achieved. Number 1, remove the mass effect immediately. Number 2, maximize the clot removal. Don't let any blood behind. Number 3, minimize iatrogenic injury. Number 4 is direct visualization for hemostasis, getting to that vessel that caused the hemorrhage so that we can avoid rebleeding. Number 5 is decreasing the length of stay of these patients. And number 6 is hopefully decreasing the overall cost of care for the healthcare system. So with that in mind is that these 6 principles were developed. The first one is using imaging that allows us to plan better trajectories to the hematoma so we don't cause so much collateral damage on the way. The second one is using that information to navigate our procedure. The third one is using a minimal access system that is more respectful of the cortical surface and the white matter. As we move to smaller corridors, we need to be able to see down these deep, narrow corridors, and having appropriate visualization for that is critical. Resection tools that can fit through these long, narrow corridors are also important when we're trying to get maximal clot evacuation. And then finally, of course, understanding the microenvironment better, collecting tissue and clot and understanding what are the potential interventions we can do to maximize recovery after we've removed the hematoma. So in this cartoon, we can try to illustrate all of these principles. So what you see here is an illustration of access to an anterior basal ganglia hemorrhage. You see the minimally invasive port that we have been using. That is coupled with a neuronavigation probe. So the placement of the port is done under stereotactic guidance. Here we're choosing a corridor that is respectful of 2 main fascicles. In purple, you see the cingulate fasciculus, which is medial. And in green, you see the superior longitudinal fasciculus, which is located lateral to the hematoma. And we're going along the long axis of those fibers so that we transgress the least amount of fibers and cause less disconnection syndromes. And then once we have reached the target and we remove the obturator, then we bring in this exoscopic visualization system so that we can deliver a lot of light and magnification to the bottom of the target. And then we have the things that we normally use in microsurgery. We have a suction, we have a bipolar device for cautery, and we have a tool that efficiently resects the hematoma. So that puts it all together. So let's walk through a case example. So this is a 74-year-old patient with a history of hypertension and diabetes that presents with a basal ganglia hemorrhage. Patient is intubated, has a left hemiparesis and a high NIH stroke scale. So you can see the trajectory that we would like to follow there, from anterior to posterior, from superior to inferior. So this is the imaging that we obtained before that. This is an MRI with a 30 direction DTI protocol. And that shows us what was illustrated in the cartoon. the cingulate fasciculus, which you will see here displaced medially right here. And then the SLF, the superior longitudinal fasciculus, has been displaced laterally. So if we pick this trajectory, we're able to maintain the integrity of these fiber tracts without transgressing them. And this is the simulation of how that cannulation would take place so we can plan our incision and our craniotomy. This, in this case, is through a forehead crease incision and a very small frontal craniotomy. So we're happy with that. We've simulated what that's going to look like. And we explore how many degrees of freedom we have to be able to cover the full volume of the hematoma. So if we pivot in any direction, 15, 20 degrees, we know how much ground we're able to cover there. And then we proceed to the operating room. So this is an intraoperative video of that. The patient's skull base is going to be at the top. The vertex is going to be at the bottom. Midline is going to be to the right side of the screen. So at this point, we've made a very small craniotomy, and then we're doing a dural opening that is about the size of the minimally invasive port, which is 13.5 millimeters. We're opening the superficial arachnoid over a sulcus, and here we have a 75 millimeter port. That port has reflective spheres so that the navigation system can recognize it, and we're introducing it under stereotactic guidance. Once we have reached the depth of the hematoma, then we remove the blue obturator. You'll see that coming out. And we're using a robotic exoscope system. So as soon as we are there, we activate the robotic exoscope and it auto aligns to the target. And we see the hematoma at the bottom. And as soon as we touch it, it sort of erupts. And then we have an automated suction resection tool. That's what we're using to resect the hematoma. So we start to remove the clot, and this is, I showed you a little caption of this, but this is the vessel that we think caused the hemorrhage. We identify with our suction and then cauterize it to avoid any rebleeding, and then continue with the evacuation in a systematic way. You can see all of these clot coming out nicely. And then once we're happy that we have removed all of the hematoma, then we do a very thorough inspection. All of these patients have a CT angiogram preoperatively to make sure that we don't have an AVM or another source of the intracerebral hemorrhage. And then here we inspect to make sure that everything looks dry and there are no surprises. And as we start to retract this port, we retract it in 1 centimeter increments, and then we inspect the banks of the cannulation to make sure everything looks dry. We put in a little bit of Surgiscope for that. And then we continue our systematic decannulation along the path of that until we are completely decannulated. So now the port is coming out. You see the last part of that. And then I'll call your attention to the cortical surface. You see the cortical surface is preserved and those veins at the surface are preserved. So we have tried to be as respectful as we can of the cortical surface and the subcortical white matter associated with that. This is the evacuation, the post-evacuation scan, so a very satisfactory, good evacuation of the hematoma. And then the patient moved on to rehabilitation after a short length of stay in the ICU. So the technique I just described to you has been evaluated in preliminary studies that were published a few years ago. The one on the left was a multi-center study that had 39 patients, and the two on the right are from single center institutions. One is from the Cleveland Clinic and one is from St. Louis University. And the important thing about these results is that number one, the clot evacuation results were very substantial. In the multi-center study was about 90%. In the Cleveland Clinic study was about 96%. It's one of the highest ever reported. And the other important thing is that the Glasgow Coma Scale of these patients improved from preoperative to postoperatively from a median of 10 to a median of 14. So very encouraging pilot studies, although in very carefully selected patients. These were Also, part of some meta-analysis that were conducted between conventional surgery and minimally invasive interventions that showed a positive signal towards minimally invasive approaches being more beneficial and reaching better neurological outcomes. So those studies and the results of this pilot data were taken into consideration for the most recent version of the guidelines. So the previous version of the guidelines for ICH management were published in 2015. The most recent version was just published in July of this year. And in those guidelines, there are some important things. The first one is that the guidelines state that minimally invasive evacuation can be useful to reduce mortality. This is coming from the MISTI data. It says that it may also be reasonable to choose a minimally invasive evacuation approach over a conventional craniotomy to improve functional outcomes. And finally, it says that the effectiveness of minimally invasive evacuation to improve functional outcomes is still uncertain because MISTI did not reach the primary outcome. And hopefully other trials will. But as always, the guidelines conclude that high-power randomized control trials are needed to prove optimal patient selection criteria and the ideal time to surgery. So with that in mind, we put together a multi-center randomized trial that is called ENRICH, Early Minimally Invasive Removal of ICH. We have a scientific leadership team with neurocritical care physicians, neuroradiologists, stroke neurologists, and neurosurgeons, and we have an economic outcomes team out of the University of Pittsburgh. We have 32 sites that are participating in this trial, and this is our website, enrichtrial.com, if you'd like to learn some more about it. But the purpose of the trial is to provide clinical evidence of a functional improvement, of safety, and of an economic benefit when we compare ICH evacuation to medical treatment. This is a multi-center, randomized, adaptive clinical trial that compares standard medical management to early, within 24 hours, surgical hematoma evacuation using what we've called the minimally invasive parafascicular surgery approach in the treatment of acute spontaneous supratentorial intracerebral hemorrhage. It is an adaptive clinical trial, and I will go into some detail about what that means. We are doing block randomization based on the location of the hemorrhage, and we have two locations, the anterior base of ganglia or the lobar locations, with subsequent enrichment on location. There's no restriction on the number of subjects enrolled per location, and our sample size was ranging between 150 and 300 subjects, with interim analysis that were planned to be done at 150 patients and every 25 patients up until the full goal of 300. The inclusion criteria were ages 18 to 80, patients with a CT scan showing a primary intracerebral hemorrhage with a Glasgow Coma scale of 5 through 14, volumes of 30 to 80 cc's, and a study intervention that could be initiated within 24 hours of last known normal, ideally within 8 hours. Historical MRSs, of course, had to be 0 or 1 for a good baseline. And these were our exclusion criteria. First one is no other causes for the ICH, no aneurysms, AVMs, vasculitis, etc. They had to have an NIH stroke scale that was greater than 5, so they were symptomatic enough for us to detect an improvement. Patients that were salvageable, so no one with bilaterally fixed and dilated pupils or extensor posturing. They could have intraventricular hemorrhage, but not more than 50% of the lateral ventricles, because at that point, there's a lot of morbidity from the IVH itself. No primary thalamic hemorrhages, and we made that exclusion based on our preliminary pilot data, because when we looked at the length of recovery for anterior basic ganglia and lobar hemorrhages, patients reached their maximal MRS at around 6 months, whereas patients with thalamic hemorrhages took a lot longer, most likely because of that thalamic component. Um, no midbrain pontine or cerebellar hemorrhages were to be enrolled. No anticoagulants that we couldn't rapidly reverse. No patients with coagulopathies associated with end-stage renal disease or end-stage liver disease. We had some platelet and INR goals. No signs of systemic coagulopathy, such as bleeding from other sites. Patients had to have a life expectancy greater than 6 months. Um, no reasonable expectation of recovery, DNR, or comfort measures. And then no patients that would be hard to follow. So chronic alcoholics and drug addicts with no reliable support network could not be enrolled because we couldn't follow them. So those were our inclusion and exclusion criteria. And I'm happy to share with you that we completed enrollment about a month ago. We enrolled our patient number 300. So we have closed our enrollment. So the follow-up of these patients is 6 months. So we will have the final results in the month of December. We should be collecting the last modified ranking scores. We'll have to run the analysis. So hopefully by January or early February, the latest, we will be able to share the results with everyone. Hopefully for the International Stroke Conference next year will take place in February. So when we look at the reported evacuation rates for several of these studies, Stitch was suspectedly about 40 cc's. Stitch 2 was about 30 cc's of the median volume of the hematoma, but we didn't know what the clot evacuation rates were because they didn't report them. For Misty 2 and Misty 3, the clot evacuation rates were 57 and 59%. For MySpace was about 90%. That was the multi-center study that was done with the technique I just described. The Cleveland Clinic report I mentioned was 96%. And there's some other studies that have been done with endoscopic devices. One used a device called the Apollo device. The evacuation rate reported for that was about 54%. There's a much better technique now with a different device that is reporting rates around 90%. And this is the group from Mount Sinai led by Chris Kellner and Jay Moko in New York. So there's a lot of improvement and the clot evacuation rates appear to be getting better. And there's a lot of activity in the field. So when you look at the number of active ICH trials on NIH.gov, this is what we have. You see ENRICH at the top. The second study is the SWITCH study, is the Swiss decompressive craniectomy trial. So they're revisiting doing decompressive craniectomy and clot evacuation with the traditional technique. That's an ongoing trial. MIND is a study using a device that works through an endoscopic channel, and it's currently ongoing. There are approximately 6 sites there, and the enrollment goal is 500 patients. There is INVEST, which also uses another endoscopic device there as well. You see the names of the 2 devices there. That's an ongoing study, and the enrollment goal is 50 patients. The DIST is the Dutch intracerebral hemorrhage trial. It's using the same technology as MIND and INVEST. Is being done in the Netherlands. And they are actively recruiting. The RISA study is doing a minimally invasive approach with an endoscope as well. That one is being done in China. And there are a few others that are also exploring some different iterations of thrombolytics. So there's a lot of activity, a lot of trials are ongoing. To me, the ones that are most exciting, in addition to what I just presented to you, is this Scuba Technique, which is an endoscopic approach that Chris Kellner and the Sinai group are doing. They've developed a lot of expertise with this, and they have some great results in terms of clot evacuation and outcomes. This is a short video of that. It's definitely, there's a learning curve to this. You can see that the visibility, of course, is not great because you're working with a ventriculoscope in a bloody field and you're in a parenchymal cavity. So the goal is kind of to make that parenchymal cavity into a ventricle by insufflating it with fluid and then evacuate the hematoma until at the end you have this cavity that you can inspect and try to identify the bleeding source and cauterize it if you can. So it's not an easy thing to do, but Chris has done, I think, over 300 of these cases, and he's developed good expertise on it and shows some great results. There's a new device that team also worked on. It's called the Surgiscope, which also uses a port. The difference with this port is that the optics are mounted onto the port as opposed to using an external visualization tool like an exoscope or a microscope or an endoscope. So that black thing that you see there is a camera. It's kind of like an iPhone camera that would be looking down. And then you do your evacuation with a system that suctions and morselizes the clot. This is another device coming out of a group in Taiwan University that I also think has a lot of potential. It has also a built-in camera that is at the tip of the device, and it uses suction and morselization of the clot. And they've presented some very interesting preliminary data with that, with very good evacuation rates, good safety data, and good decrease in length of stay. So lots of activity. So what do we get out of all of these devices? I think that at the end of these trials, we are not going to have a silver bullet, a single approach that will be good. I think we'll have more nuanced approaches. For example, if you have a lobar hemorrhage that's about 80 cc's and the patient presents over 48 hours, that patient already is going to have so much edema that probably a hemicraniectomy with a clot evacuation with whatever device you see fit is going to be necessary. A 30 to 50 cc anterior basal ganglia hemorrhage maybe that presents early, less than 12 hours, may be an ideal approach for a port-based evacuation. Whereas the thalamic hemorrhage that is medium size in range, that's 12 to 24 hours into the hematoma, may be a good case for a MISTI approach. And I think we'll see these trials providing evidence to develop these more nuanced approaches as time goes on. So that's an overview of where the field of ICH is, what minimally invasive evacuation has evolved into, and the trials that are ongoing, and hopefully I'll be able to have ENRICH data to present at ISC and share with you in the near future. Thank you again very much, and with that, I'll take any questions.
Thanks, Dr. Pradilla. That was terrific. Really great overview, and it's been, I think, a source of frustration for almost everybody involved in neurosurgery that what seems like an operation that is, so intuitive and seems so effective in many cases that we can all remember, that it's been so difficult to demonstrate, the clinical utility of it in a really prospective, solid way. So I certainly applaud your efforts along these lines. Clearly, industry is betting that it's going to be effective. I'm wondering if you can give us a little bit of a hint, though. What I'm concerned about is you were having interim analysis in the ENRICH trial after 150 patients, every 25 patients. You had interim analysis, and yet the trial continued to completion. Should I be anxious?
Well, I am. I am anxious about it. We did not meet early futility for the trial. So we didn't stop it. We did not meet early success either. But we did trigger an enrichment rule. And that triggered the second interim analysis when we were at 175 patients. We enriched for location. So we stopped enrolling basal ganglia hemorrhages. Now, it gets a little bit complex when we talk about how Bayesian statistics and adaptive trials are done. But the summary of it is that you take the data in a preliminary state. So your final analysis is done with your modified ranking score at 6 months. But as the trial goes along, you collect modified ranking scores. And at 90 days, you get a modified ranking score, and then you model what the study is going to look like. So we ran over 1,000 simulations as to what the outcome would be based on the modified ranking score at 90 days. And that told us that the probability of success was low if we kept enrolling both locations. And therefore, but the probability of success was high if we stick to lobar. Now, it's tough because that doesn't tell you that basal ganglias are futile.
Right.
It's talking about your risk of overall success. So we will have the final data for both revealed to us at the end of the study as to really what was the MRS at 6 months for the basal ganglia. The decision was taken by the statisticians when we only had 90-day MRSs. So I really don't know where that's going to fall. But it's intuitive to think that the basal ganglia did not do as well as the lobar ones. I think there's still a benefit, and I made a small comment about it in the beginning as to the fact that if you have that patient in the ICU that will stay there for 10 days, and you can shorten that length of stay to 5 because the ICP is no longer an issue and you can extubate them and move them along, that's going to be beneficial. And we're looking at that. We're looking at length of stay as one of our important measures, and what that represents in terms of quality adjusted life years for the economics of this.
Right. I noticed that as you were describing the trial that the economic outcome was one of it. So the primary endpoint was again an MRS outcome, but the economic potential benefit was one of the secondary endpoints. Am I understanding that correctly?
Yeah.
Yeah. There's a question from the chat asking about whether you leave the bone flap off. So I think that's probably relating to at the end you gave sort of the potential triage and the large ADCC and larger ones. And so the question is asking whether you leave the bone flap off and preserve it in the abdomen there, or what your personal thinking is in that situation.
So when we do this minimally invasive procedure, the craniotomy is very small. The incision is usually about 4 or 5 centimeters. The craniotomy itself is about 3 centimeters. And the dural opening is 15 millimeters. So the bone always goes back. And what we typically see, and you saw that in that evacuation, is that in the beginning, the brain's very full. Once you take that clot out, it collapses and starts pulsating normally. So we haven't had to do that in the trial patients where we had to convert to a decompressive craniectomy. But that's probably because the selection criteria are narrow. So if you take a patient with a larger hemorrhage or a patient that just showed up after 72 hours, then and you're doing a conventional decompressive craniectomy, then yes, for those patients, we do leave the bone flap off and we freeze it in our bone bag and put it on 3 to 6 months later.
A couple of questions about the equipment, and one is I was just wondering, are there any implications in this trial in terms of FDA approval for devices? If, for example, the trial is positive for the lobar hemorrhages and negative for the basal ganglia. Is that having an approval implication?
So, but although the devices that we use are FDA approved, they're all FDA cleared for surgery in the brain, and people use them routinely for brain tumors, clot cysts, many other applications. So whether there will be an IND for specifically this based on the trial, I don't know the answer to that. But the devices are commercially available in many countries. They're now being used in Europe and in Asia fairly routinely.
And there's another question in the chat about locations that are maybe have lesser access to things like tractography, and asking what your approach would be in the absence of access to tractography for these cases.
So there are three primary corridors for access. For anterior basal ganglia hemorrhages, that trajectory that I described, coming frontal, and it's about the mid-pupillary line, the location of access, that spares those two fascicles, the cingulate and the SLF, very routinely. And that is a fixed corridor that you can use without necessarily getting tractography. There is a corridor that we call the posterior corridor that is through the parietal occipital sulcus. If you enter from the top of that corridor down towards the thalamus, you are sparing the pathways that you want to protect. So you're sparing the arcuate fasciculus, which stays lateral to that entry point. You're sparing the ascending rami of the SLF, which stays above you, and we're sparing the optic radiations, which stay below you. So for thalamic locations, that one is something that you can try, but for ICHs, we have had surprises where we think, oh, the arcuate and the SLF are clearly going to be out of the way, and we run the tractography and they're in the way. So those are a little bit more difficult to do. And then the ones that are lateral in non-eloquent traditional areas are fine. If you have a high frontal or a anterior temporal, that may be okay. But anything close to SMA or primary motor areas, I would try to get tractography as much as possible.
Great. Dr. Patel, I see you got a hand up there.
Hi, yeah, thank you, Dr. Pradilla, for an excellent lecture. One of the things that I've noticed over the years since I've been following this as a resident and now as an attending, is that, you know, the technology continues to improve, the imaging improves, you know, you talked about the tractography, and yet the outcome measure is so crude, modified ranking. I feel like that is the weakest point of all of these things, the subtle, you know, thing, when we're like dissecting through tracks and trying to avoid certain things, you can't pick that up on an MRS, you know, scale. And so I think one of the problems is that the reason why we get all these equipoise, you know, situations or results that are not that clear, you know, left hemisphere versus right hemisphere is not delineated, those kinds of things, it's sometimes impossible to tell a difference with the current. So have people thought about like better outcome measures to help, you know, move the field forward? Because the MRS, I think, is just outdated.
Yeah, that's a great point. So yes, I completely agree with you. It's a very rough tool. We use something slightly different called the utility weighted modified ranking scores. So when you do utility weighting, you're putting more value on a more desirable outcome for the patient. So a patient that goes from a 5 to a 3 gets a much higher weight, because then they're going to become potentially independent at some point. So that's the rough way to do it. We have some small cohorts where we've done neuropsychological testing. The challenge with that is cost. In the confines of putting a trial together, just to give you a sense, you know, a trial like this goes north of $10 million for 300 patients. So when we build what are we going to use, that obviously is a constraint, how much money we can put into the neuropsychological outcomes of this. But that would be, if I had unlimited resources, it would be using a standardized neuropsychological battery for this. The other thing that we have to do is use a measure that will allow us to compare data to other trials. So Stitch and Misty and all these other studies have used MRSs in the past, and we needed to have something that was comparable for that.
Great.
Thank you.
We're coming up on time. I want to try and get one more question in from the chat, and the question was asking about if you knew in the trial what the average duration of intubation and ventilation time was, if you had a sense of that being shortened. For the trial patients, I don't. I can tell you for the preliminary data that we had in the multi-center study, the mean length of stay in the ICU has been compared to historical controls. And there's a paper that looked at the economics of that Mitesh Shah and the group at Indiana University published. And they had a reduction in length of stay and a reduction in cost that was statistically significant. I think the control group had something on the sort of 10 days, and they decreased it down to about 5 days. So it was almost a 50% reduction in length of stay. That would be a huge deal for us. We're constrained currently with nursing and critical care beds. So that was an excellent presentation. I really appreciate you being here this morning. Thanks so much, and good luck with your trial. Thank you so much. Nice to chat with everyone, and thanks for the invitation. Thanks. Bye-bye now. Bye.